sectioning. But where do you think we're going to go for the nasopharyngeal? We're going to go through the nose, aren't we? So what you'd do is that you'd bump up your O2 up to 6 liters and hyperventilate them a little bit. Then I would ask the partner to remove the nasal cannula.
How long do you hyperventilate?
Usually you give them a minute in between, and I usually hyperventilate for a minute.
Okay, the entire minute.
So then now, what you do for nasopharyngeal, how far do you put it down? You measure from the nose to the earlobe, which is probably around 6 inches on her. Okay? So then you would, again, check to see if the suction's working. So then you let her know what you're getting ready to do, and you don't put on the suction until you get down there. So I'm gonna go down this nose. I'm gonna see, and I don't know whether it's gonna work, y'all.
Alicia had a question.
Oh yeah, sorry. So, the cannula.
Yeah, y'all don't do this now. Okay, let's pretend I went down 6 inches. I went down 6 inches, and I put here, and then you do this in between your fingers.
So you just roll it around.
You roll it around between your fingers, right there. And then you take it out, then you clean. If you're doing an oropharyngeal suctioning, maybe this one will be a little easier. But again, around 6 inches right here. I don't know how she's gonna work. You'd go down around six inches, and then you'd go, and then you put the oxygen back on. Put the oxygen back on.
Oh, sorry.
Are those the same amounts of time, like three
Yeah,
max?
you should never do more than 3 times in one episode.
Of any type of suction?
Any type of suction, because you're depleting the oxygen. So while you're doing that, you put the oxygen back on and you're hyperventilating. You've now finished with the suctioning of whatever you're going to do. And then you would take this off, put this back over here, put that back over there, up there. Then you want to do this. You do like this. And put this in the trash. Hopefully I'll be able to use this again. Then you clean up your mess, straighten her up. Now, before you stop, you want to cut this back down to 2 liters. You want to get her nice and cleaned up, and then you want to get this out of the way. Kind of straighten everything back up again for her. So, and you put everything, table overhead, raise the rails, whatever she needs. Make sure she's comfortable. Then I would go get my vital sign machine over here, and I would listen to her lungs to make sure that that's helped her breathe a lot better. Then I would check her O2 saturation. Because where do you want the O2 saturation to be?
90 or above.
90 or above. You would check the O2 right there. You'd make sure she's comfortable. So what else do we want to say? What else do we want to say about this?
Let's find out if she's got any pain, maybe.
Well, we'll put the bed down and all that. Again, when you're doing this, chances are if you have a patient that has a trach, you're not going to have as many patients as a nurse who has just regular patients. So you're probably going to know your patient real well. And again, making sure you go into the room and you check their ID, ask them, I always verbally ask them, or the family member that might be there, are they allergic to anything, to make good and sure the record matches? Yes.
In the video when they were doing the nasopharyngeal, they moved the oxygen to the other nostril. Is
And
that a thing, or just?
you can, if you can do that, she's not really built where you can do that real well, but that's okay. You can do that. I just usually take it off, suction, and have it put back on.
Okay.
Okay? To me, that's faster, and I don't have to worry about dealing with this because it's not going to take me long to suction. So I just take it off. You know, I have the partner take it off and I suction.
Should we worry about that if it's like our first time?
You're not going to go in there and do it by yourself.
Okay.
Thank
Okay.
you, Jesus.
Most faculty,
Thank God.
this is something that I usually go with you 2 or 3 times just to make sure you do it correctly. Never allow students to go in and do something like this. Even if you checked off in a skills lab, you just don't do this by yourself. Okay, and usually by your med-surg years, if I know that there's 2 students that are real good at it and I've watched them 2 or 3 times, then you can go in there and you can do it. But I don't turn anybody loose on anything. So rest assured about that. Okay, is there anything, the video, we don't have certain things that the video shows. If you was removing an inner cannula, you would pull it out. You would pull it out and turn it to the side to take it out. If it's a disposable, you throw it in the trash. If it's a reusable, that's where we would have to scrubby dub with the little skills, you know, the little scrubby dub things in here. So I'll show you how to do that. Now, the video shows you to use water and hydrogen peroxide. We're just using saline, okay? Different places do things differently. I've used it both ways. Some places want you just to use normal saline. Others want you to use that mixture of hydrogen peroxide and water. You have to know what the facility's policy is. The trach cleaning, some facilities say it's a clean procedure. Others say it's sterile. So let me tell you about this. So you're on the safe side. You need to look at the policy, see what the facility's policy is. Then what you need to look at is it a long-term trach or is it a short-term trach? Back in ICU where somebody's just had surgery and they need a trach so they can survive for a short period of time until they're stabilized, that would be a very sterile trach cleaning. If it's somebody in an LTAC that's had a trach for 5 or 6 years, that's long-term and that's more likely clean. And they probably are just using sterile water. Never let someone tell you to use tap water. I don't care what you're doing. Never use tap water on this. So you see there's some differences based on what's going on with your patient right there. Okay. So, any questions about that? On the cleaning. Okay. So now we want to do trach cleaning. So it says that you need a trach cleaning kit. Usually you'll have either a disposable inner cannula in here, which y'all's don't, or you will have the tools to clean the inner cannula. I usually make sure that you should have, this doesn't tell you what you have in here, but I looked, you've got some sterile gloves, you have got a pad, see what else do you have, you got the tools to clean an inner cannula, you got a 4x4 to dry it, you got Q-tips, and you also have a, what you call a trach 4x4 that's cut to fit underneath the trach collar. So now this trach 4x4, it's usually something more than just a gauze. It's the type of gauze that doesn't shred. So do y'all know the reason why you have that trach dressing that fits underneath the trach collar? You want to make sure you use a material that does not shred because you don't want any of those fibers to go down into the trach.
Okay.
So that's why you need to
That
make
makes
sure
sense.
you use that particular trach dressing right there, because it's slit and it's a real smooth material, and you don't have that to worry about. Again, I would clean my table off. I would let the patient know what I'm doing. I would get my 2 identifiers, making sure that they understand the signs or symbols to make sure that I understand if they're in pain, they want me to stop or whatever, because they can't talk. Right there. And so I'm not going to need my suction, but they do have the oxygen right there, or should have oxygen on here. And usually with the trach, during the procedure, you'll take them off the oxygen, and in between you'll give them some oxygen bursts so you can clean them. But you don't want to deplete their oxygen state, so you want to constantly be aware of it and what you're doing. So then you would tell them that you're getting your stuff ready.
I have a question about this.
Okay.
People in this state, or maybe in this situation, are they gonna have a pulse ox on them at all times?
It depends on how serious your condition is. An acute one back in ICU is going to have all kinds of monitors and stuff, and you'll be able to glance to see what their O2 sat is.
Okay.
Somebody that's in an L-tank unit, they've had this for 5 or 6 years,
Mm-hmm.
and I don't care if they've had it for 5 or 6 years. I check their O2 sat on the, I get the vital sign machine, and I check their vitals and their O2 sat.
Okay.
I just check it just to make goodness sure that they're okay after I do this procedure. Because you want them to, they got to have good oxygenation.
Right.
And so, because that's going to cause all kinds of problems if they don't. So, again, I can put a towel up here or anything. And I'm opening this up. So, right here you see this kit right here. And it says that you can, see, I'm trying to do what it says. It says that you can use these different things for sterile right here. So then I want to make sure that I pinch my gloves out without touching anything inside. Well, this is not set up like I want it to, so as you can see. Okay, I want this to be as clean as possible. And of course this usually fits a little closer underneath them, right there. So, now, I need some hydrogen peroxide in water or sterile water. So I make sure, I look at my label, I got my hand over the label, and I pour some in here. Then I'd pour some hydrogen peroxide in there, if that's what I'm supposed to use. And then I put the lid back on without touching the lid rim or anything. Then you can use, see, I got, and underneath here, since I looked at it already, you've got that particular type of dressing for your trach, underneath the trach cuff. Then you have also got just a regular 4x4 so you can dry them off underneath, because you want to make good and sure you keep it dry underneath that cuff. Because that moisture, what does moisture do?
It's going to help the skin break down.
It grows bacteria.
Oh, yeah.
And I got some more of these crummy gloves. Okay, these are not gonna work.
Can I ask you a question while you're doing that? Did you flip that over on purpose? The sterile thing?
Yeah.
Okay, that's because that's the waterproof side. I don't know what side's what.
It's waterproof one way or the other.
Okay.
I probably got it turned around because I touched some other stuff on the
Okay.
other side. So I put it up here, but it will prevent water from going through and getting on the bed.
Oh, okay.
Okay, so which one of my hands is clean and which is dirty?
Clean and dirty.
Okay. So I can do everything, you know, right here with this dirty hand, and everything over here I can see. This is sterile right here, or I could easily put this over here. See, this is sterile. Here's the regular 4x4. Oops. Regular 4x4, and here is your trach dressing.
Okay.
Okay? It's nice and smooth, and it fits up like that. So I can put that right there. So then here is your trach collar. And this is an old-fashioned one where you have to do it all the time. So we're gonna put this right here. Because she's kind of like comfortable right there. So I would normally undo the oxygen, take out the inner cannula with my dirty hand, take out the inner cannula and throw it in the trash if it's disposable, or I would put it in the hydrogen peroxide water mix and let it be cleaning. So then, see, you have all these paraphernalia and things right here that you could use to clean that inner cannula. So you would take this, you would be able to pick up your inner cannula after it's been in the water right here, and you could scrub it right there, get it all there. And here's your Q-tips right here. So you would normally have a cuff already there. So what you would do is you would saturate it, and then you still have your oxygen on right here. So what you would do, you'd go underneath the cuff, and you could remove the oxygen that's connected, the T-tube, but you would go under the cuff, one swipe around the opening. You see this Q-tip? You'd go around like that and clean it. One swipe. Do not go over what you've already cleaned.
So one swipe with a Q-tip.
Then you would do, and you see which hand I'm using right here. I'd go in over here, I'd go under here, one swipe. I'd go back over here, I'd go around until I one swipe around each side right there. I'd use the Q-tips and I'd make sure I get all that crust and junk off. Because it crust up, it's an artificial opening, and you're gonna have crust. But you'd take one swipe, you'd go around it, and never go over the area that you cleaned with the Q-tip again. You just, each time you use a Q-tip, you'd make one swipe. Okay, so then you got that, then you put the oxygen back on, okay? Then with your clean hand or sterile hand, you'd pick up your 4x4, and you'd lift it up like it shows in the video. You would dry it. Again, if you look in the video, it's really hard for them to keep everything nice and sterile, but you want to dry it because you do not want that to stay damp. Then, with your sterile hand, you would put it underneath there. And you'll pull it up, but you have to put it in underneath each side up underneath it, like that. And usually, again, you're gonna have a Velcro or whatever. This is one of the old-fashioned ways of doing this. So my heifer, My heifer is gonna help lift her head up. You're gonna get this center right here. Okay, there we go. Is it? Okay, so the deal is you want to get it around the neck. So it says one side at a time. You would untie it, slip it off, and then it has loops in it. I don't have any loops to show you, but you'd put this in between the loop. You'd put it in between that loop and tie it. I'm gonna pretend I'm tying it, y'all. Okay, so then I pull that oven out a little bit. Then I make good and sure this is come through here. Then while my partner, see, I might even have my partner be holding it. Because see, now we're getting to where we're gonna unloosen this side. So she might even stabilize it, and I would pull it. Y'all pretend this is tight. Okay. So then I would pull it through, and I would tie it. It's not tied like this, but I don't have anything to put it through. Okay, so now you got that dressing. So then I can untie that other one, and I can pull it through, and I can put that in the trash. So then now you've got a nice comfy trach cuff. And how many fingers should it be loose underneath?
2.
Okay. Because that's what it said. It said 2 or is it 1?
It
Which
says
is
1 and 2. But
It-
like 2
1.
kind of snug, I think. They said 1 and 2. They gave 2 different.
Oh, they said 1 and, see, they gave 2 different things?
Yeah.
I said 1.
Okay,
2
so
tightly and then 1 kind of loose.
it says place 1 finger under the collar to ensure it is not too tight. So this is what your checkoff
Very
says.
one.
So I believe
There's the
Dr.
1.
Castile wants y'all to put 1 finger down underneath it. So you'd want to put a finger underneath it, because you don't want to choke them. Okay. Okay. So it's nice and comfy. You'd want to clean up your mess. Then, so you replace the inner cannula. Maybe it's disposable, maybe it's not. You've got that replaced and all that stuff. Then you put the oxygen back on, and then go get your O2. You want to make sure that you check the O2 set, because you've kind of jacked with it, remove the O2 so you can do all this changing right here. And so you want to make sure that the O2 set is at least 90 plus, and you take a set of vital signs, because that's a good measure of how the patient tolerated it also. So check their vital signs, make sure that they're comfortable. Then you would want to clean up your mess. You want to dispose of your personal protective equipment appropriately. You'd want to get this off. Get that off. Raise the rails up. Make sure everything's out of the way. Put the bedside table like it's supposed to. Put the call light within reach. Have the patient indicate how they felt they tolerated the procedure. Then you would clean up your mess, put everything in the trash. You would tie it up. You would wash your hands. You would take your gloves off, wash your hands. You would put a clean glove on to take your red bag waste down to the solid utility when you go out of the room. Then what would you document?
Vital signs, how the patient handled it, their O2
Okay.
saturation.
You would, and particularly with a suction, you want to document how much you got. Was it a copious amount of drainage? What color it was? Did it have blood in it? How did the patient tolerate it? Did you have to give them some pain medication before you done the procedure? You know, you put all that information in there.
Where is that suction stuff going? In that?
Now, see,
And-
this is your suction right here.
And that's where you're gonna measure.
And yeah, and you'll look at it, see, and usually you'll suction it out and you clean out your tubing with the saline. But you look at it and see what color it is. If it's green, it's old. If it's yellow, it's infectious. If it's bloody, you need to find out, what did I do?
Mm-hmm. Oh, God.
Yeah, believe me, your nose is tender sometimes. People that have abused antihistamines and stuff for a long period of time have a tendency to have very fragile tenormin. And you stick anything up here and you're gonna tear the skin and cause it to bleed.
Okay.
And so that's why you might get the blood. You shouldn't be getting any blood from the trach unless somebody has cancer, they've been hemorrhaging or something like that. You shouldn't be getting that type of stuff from the lungs, but if they have a major infection and have lots of fluid, you might get some blood tinged, yellow, nasty looking sputum.
Okay.
You might get that. So that's the reason it's important to chart what it looks like. Because, you know, you need to know the status right there. If it's clear, that's good stuff. It means it's not infected or anything like that.
Is that considered intake and output?
You have to be careful about that because you have to know how much saline you put in there.
Okay. So
Because if you put if they have some real sticky secretions and you have to use a lot of saline to get it out of the tubing, you're going to use a lot more saline up there. That's not output. And so you have to know. That's the reason they started doing like small bottles of 250 like this.
so you can measure.
Yeah, so you can, so if you use the whole bottle, you know, you use 250 cc's. This has, I think, this is 1.5 quarts. This is 1 liter in here.
So if you get more in the suction than you get out of there, then you're pulling some from somewhere you shouldn't be.
And so, and usually if it's nasty and thick and you can really get some nasty stuff.
Ugh.
You can.
I know.
You need to know just exactly how much you're using. So on a shift, if you use a whole bottle like this, you would know that you use a liter of saline up there, and you would subtract that, or you'd put irrigation, you'd put 1 liter,
Okay.
because that's where it would fall under right there. But that's what you need to be looking at. Never go any higher than 150 on the suction. If you have a nasal cannula, hyperventilate during the procedure. It's 6 liters, but don't forget to put it back down to 2 liters.
Okay.
Because you'll dry their nose out and cause it to bleed. And if they got COPD or stuff like that, you could really, shut them down. They'll quit
Yeah.
breathing on you, and then you'll get to practice tracheing.
Gosh.
So you want to make sure that you do that. Okay, what else do we need to?
I just noticed something. For the nasopharyngeal, do our kids, because I haven't opened it up yet, do our kids have like lubricant in it?
Well, see, that's what the problem is. Your kid doesn't have lubricant in it.
Okay.
And I'm used to working with lubricant. And so you just have to say,
Yeah.
I would put lubricant on there, because if I had some lubricant, I assure you it would go down the nose a lot better. But I don't have any lubricant. Even saline's not going to make it go down real easy. So,
How do you put it on there?
what's that?
How do you put it on?
While you're setting up, like you see this, I was using this as my Sterfill.
Mhm.
I would squirt it there,
Okay. On the sterile.
And then dip it.
Dip it.
and you just dip the end of it to make it go down.
I haven't
But
even
then
watched
it
the
would make
videos,
it go
so-
down a lot easier. It's easier on the patient. It's just like an NG tube. It goes down a lot better if you have some.
Well, it's the same with a catheter as well. Foley catheter, you always put
you
the
want to put some lubricant
lubrication
on
the
it.
end.
Yeah, I would think.
Yeah.
Okay, that's gonna help. All
Yeah,
right.
Another question. So in the video too, they were doing like the nasal and then the oral, but they were like, she did each nostril and then she went in like the mouth. Now, I couldn't tell if she was using like a different tube or just
She
like
wasn't. She was using the
just
same
cleaning
one.
it with like the saline. Is that what
See, and
makes
this
it
is the
okay?
order this is the order you go in suctioning. Traching, nasopharyngeal,
Mouth.
and oral.
Okay.
Because I've done all three on ICU patients, and that's the order you go. You want to go traching, because that's the most sterile area. Then you want to go down to the nasopharyngeal, because that's the back of the throat, and on down that way. Your mouth is the dirtiest part of your body.
Mhm.
Believe it or not, it's the dirtiest part of your body. So you want to go down the nose next, and then you want to go down the mouth. So that way you can hit all three of them and not contaminate a more sterile area.
So if you're hitting all three like that, you have to wait how long in between each
A
system?
minute between each
Just
one of
each
them.
system?
Each system, I mean, you hyperventilate. If you're doing a trach, you're going to be taking this off and suctioning.
Mm-hmm.
And chances are, if you have a trach, you're just going to be suctioning. You're not going to have any O2 up here. So you take this off and do it. And so you, if you need to suction the nose or mouth, you would leave the O2 on here and do it. It's just whatever you're doing, you make sure that in between the suctioning, they're getting hyperventilated.
Okay.
And I say put a minute in between everything.
Okay.
I don't care, and never do more than 3 times.
On each device? Like
No.
on each
If
hole?
you're doing this on one person, one time, and one time.
Okay. Because a minute ago you did 3 times on just that.
Well, see,
That's
but
why.
I was showing you the trick.
Okay. I'm just making
So what
sure.
if it's like really, really gross?
That's.
If
yeah.
it's really gross,
Like there's a lot of secretion.
I'm
You would have to go
sorry.
in it more than once.
I'm sorry. 3 times.
Okay.
Then you give it a rest for around an hour.
And then come
Yeah,
back.
but you're gonna see some nurses just keep on doing it. You really put your patient in bad shape if you do it like that. You give it a minute in between 3 times. And if you're doing it correctly, you'll get enough to where you can get their airway open, and then give them around an hour before you go back and do it again. But you gotta be careful, because you will suck out all their oxygen, and then you're gonna have major problems if you're not careful with this. Okay. And so that golden rule, a minute in between each one. But then for check-off purposes, to make it a little easier and smoother for y'all, trach first, nasopharyngeal, and then doing oral. If you do all 3 of those, you got a good idea about how it needs. And by Friday, maybe we'll have
Who knows?
maybe we'll have a collar up here.
Yeah.
But I thought that was pretty unique right there. I found a way to, and it does take a good suction catheter real well. So that's what you got. Any questions? Again, practice will make perfect. Looking at the video, if you have all the tools and everything, it gets a little easier. She's up like this. Usually on trach patients, you don't want to put them up like this, because that's hard on them. She's in a comfortable position. You might see if she wanted to be raised a little higher, but this is a comfortable position for a trach patient. For somebody that's got COPD, needing to sit up and all that stuff, you might raise them up a little higher. But it depends on what's going on with your patient. Okay, any questions?